So yes, welcome again to our weekly virtual lectures. I am Dr. Lesogho Mawela. I'm the founder and director of the Aqua Group, which includes Aqua Training School, which is our school which is bringing these sessions to you. Thank you for always joining us, and having the strength to continue learning even when things are a bit difficult out there. So I will just reintroduce the school very quickly, and then we will then go through our case study for Josh and focusing on today's topic around how you manage patients with high viral loads and how you approach switching patients to second line. Just to say that, remember, we are running a promotion and I've seen many people now encouraging their friends to register and then ending up not even paying, for the course that they want to do. So you can either get a discount or even attend any course of your choice without paying, depending on how many people you are able to encourage to attend. So as a school, we have a vision for a better society where everyone achieves their full potential. And we do this through a selected number of courses. Just remember that we are an accredited school and we provide both accredited and non-accredited programs. These are some of the values you would love about us, but importantly, through this platform, we are hoping that you guys are able to also establish relationships amongst yourselves so that you start to share information and help each other to progress in your careers. These are some of the training programs we are offering. I just want to alert you to the last bullet that in the next few days to a week, we will launch a number of skills programs that are non-clinical and trying to help, health professionals to have very good soft skills. This would include, project management in healthcare. There's already a course which were finalized around the use of information, data analysis, and how you analyze data in your clinic or in your healthcare program, so that you are able to then make improvements in how you deliver care. You must have seen with COVID, a lot of graphs being produced and maps. So that specific course focuses specifically on these skills. Again, just reminding you of our promotion, you can see that some people are able to even get themselves in groups of 8, especially for our public workshops. And if the workshop is successful, you will get your course free. You won't even have to pay. If you register as 3 people, one of you will get a 30% discount. So, try to explore that and encourage your friends to register. If you've already registered and you bring 3 people, you might get a refund, and that is good money which you can use for other things. Also to remind you that to reach us or to contact us, we prefer the use of this email, support@aquatraining.com, for any inquiries, whether it's regarding courses or information you might need. We prefer that you use emails for communication. Now, in terms of today, we are looking at a topic, high viral load monitoring, and so how do you monitor patients who are on ARVs? So that is the first question. And should they present with high viral loads, how are you going to approach these patients, and so that you can timely switch patients to second line ART? So this is part of the NNRTI weekly virtual lectures. So here's a very simple case. So you have Josh. Josh is a 30-year-old male who has been taking a combination of tenofovir, emtricitabine, and efavirenz for 10 years. So he's a good patient, right? Now he has visited you at your clinic, and this is his anniversary. So obviously, you know by now that the patients every 12 months, there are assessments and tests that we need to do. So in terms of this specific question, let's see if I do have a way. Yeah. So here's a cocktail of assessments and tests. Are you able to decide if someone comes for their 10-year visit at your clinic or your facility, which of these assessments would you do? Are you able to see the assessment, engage with it, and then try to select, you are able to select more than one, as long as you believe that is a test or an assessment that needs to be done. I will give you additional 30 seconds to engage. Come guys, let's all vote. It's anonymous. I won't know, who selected which question. It's for learning purposes and for us to engage and to make corrections as necessary. You've got 5 more seconds to complete. Yes, go for it. Yes, so 5, 4, 3, 2, 1. So I'm going to stop the voting and I'm going to show you the results. So what we see is that we've got around 50% who believe a CD4 count should be done, a creatinine clearance should be done. Most of you believe that the viral load should be done, a urine dipstick, hepatitis B surface antigen, and then a hemoglobin at this point in time, right? So if you look at this patient is not a new patient, right? He has been on ARVs for 10 years. So basically, a CD4 count is only done when a patient starts treatment. So that is the first step. And also when they are 12 months on ARVs, right? So this patient has went beyond the period where a CD4 count can be done, unless if there's other problems that the patient might have. So at this point in time, there is no indication for a CD4 count to be done. Then a creatinine clearance, yes, it is indicated because our patient is taking a drug called tenofovir. A viral load, yes. Remember, every year at the patient's ART initiation anniversary, a viral load must be done. So that is a tick. A urine dipsticks, yes, it must be done because the patient is taking tenofovir, which can damage kidneys. So it's and besides that, that is a standard test that should be done for all patients. And then we must, in terms of hepatitis B surface antigen, it is not indicated at this point in time. A hemoglobin also is not indicated because you would only do a hemoglobin if your patient was taking zidovudine and we wanted to monitor whether the patient is developing any side effects to this drug. So basically, out of all these tests, your creatinine clearance, viral load, and urine dipsticks. Those are the specific tests that should be done. Right. I'm going to stop sharing this and then we continue with our teaching. Okay, few seconds. Right. So let's continue. So again, at every visit, you need to assess your patients to say, is there an indication, to do a CD4 count? So if they were on certain drugs, like let's say fluconazole prophylaxis therapy, or even cotrimoxazole prophylaxis therapy, and you needed to assess whether you are able to stop these two prophylaxis therapies, you would then consider to do a CD4 count, right? Not because of it's a regular test that must be done, but because you are doing it to assess if you are able to stop any of these prophylaxis therapies. Staging must be done at every visit. So that is a tick. TB screening must be done. An assessment of opportunistic infections and treatment must be done. The psychosocial aspect, including adherence, support, and counseling, should be done all the time, right? And then every visit, you want to ask if your patient is doing well. Are they experiencing any side effect? You would take proper history, examine them. You see, now the question was about annual tests that needed to be done because that is Josh's 10-year anniversary. Then you document any problems. You ensure that adherence, counseling, and education is provided. and provide the medicines that we need to provide. So again, I'll always, I'm sure you by now you notice that it's a slide that I like because it lists all the assessments and when they should be done, so at baseline, which ones must be done, and then when do we repeat these specific assessments. So you'll see that side effects assessment is something that you must do all the visits. TB screening, you must do adherence, education around safe sex. If it was a female, you would be assessing all the time whether they have missed any menstruation and then doing a urine test for pregnancy. Weight and BMI must be done. WHO staging, assessment if they need any prophylaxis must be done. And you can see hepatitis B would have been done at baseline or any time when you want to stop the issuing of the drug tenofovir. Pap smear, you can see again, CD4 count, it's baseline and not annually, right? So this is something that must be corrected. We only do it at 12 months. So a patient will only get 2 CD4 counts when they start treatment and then when they are 12 months on ARVs. Viral load, we started at 6 months, and then you can see that every year a viral load must be done. Creatinine clearance only if they are on TDF. And yes, our patient is taking tenofovir, which has as part of its side effect profile sometimes some kidney issues. So annually we would do a creatinine clearance. You'll see why I said we should not do an HB is because we are not prescribing zidovudine at that point in time. If the patient was going to be given nevirapine, we would do a blood test, ALT. And then if you're going to give lopinavir, ritonavir, or what we call Kaletra, Alluvia, you would then do a fasting cholesterol. You don't do it for all patients, including HB, not for all patients, only for those who are going to be taking zidovudine. So that is very important for you to note. Again, when a patient is taking tenofovir, which is the case, you'll do a creatinine clearance in non-pregnant adults. If you are dealing with a pregnant lady, you also rely on a creatinine level. A creatinine clearance of less than 50 is regarded as abnormal. Ne? Therefore, you might need to stop tenofovir. If the patient is taking zidovudine, or what you call AZT, you would monitor them with an HB and a full blood count. And if the HB is less than 7, it is considered to be abnormal. Nevirapine, we monitor it with the ALT, and if the ALT is more than 100, it is regarded as abnormal. You should either refer or act based on that. Remember, the other drug which is not included is lopinavir, ritonavir, and you would generally check your patient's cholesterol and lipid profile, right? So Josh's results are back. So you did do the test and the results are back, and this is where we are. So he's been taking tenofovir, emtricitabine, and efavirenz for 10 years. You did the bloods, he's back now for the results, and you can see that the last time a CD4 count was done was when Josh was 12 months on ARVs, and it was 245. The creatinine clearance is 90. Remember I said it is abnormal when? Do you remember? Let's go back here. So I said it is abnormal when it is less than 50. So at 90, this is relatively normal, right? The hepatitis B at baseline, so these were not done at 10 years, right? These are baseline results were negative. And the viral load now, it's 9,500, right? So he has a rather high viral load, which came back as 9,500. We prefer to have viral loads that are suppressed, right? So I do have a question for you to say now that Josh's 10-year blood test results are back and the viral load is 9,500. What is your plan for Josh? Which of these options are suitable as an action that you might want to take? right? Let's select, don't worry, give it your best shot. I will never know, no one will know who selected what. We've got 5 more seconds, so let's go for it. Okay. 5, 4, 3, 2, 1. Some of you are still voting. Okay, I'm going to stop the voting and I want to show you the results. So now some of you say you are going to continue the current treatment. That's probably correct because at this point in time, we only have one viral load test that is high. Remember, we do not confirm treatment failure based on one viral load. So we might still continue the current treatment. So that is part of it. Switch to second line. At this point, we think he might be failing, but we don't have a confirmation. Therefore, it will be difficult for us to consider switching him to second line. We need to give him time to suppress and repeat the test. Treatment failure is defined when you have 2 consecutive viral loads more than 1,000. There's an option to replace efavirenz with dolutegravir. It is not recommended because we have a high viral load. Remember, when you have a high viral load, you don't want to play with drugs. So here you cannot do what we call a single drug substitution. So if you have to change treatment because of a high viral load, you want to change the whole regimen, not just one drug, like just replacing efavirenz with dolutegravir is not going to work. And then enhanced adherence counseling, yes, it's a tick. We have to do that and get to understand why is Josh failing treatment suddenly and what are the challenges, that he might be experiencing. Also reviewing the drugs that we have prescribed, and then taking it from there. And then now we say the last option, take bloods for HB and hepatitis B. This is probably correct because we are thinking that he's likely to be failing treatment, and if we are to switch him to second line, we might need to give him some of the drugs like zidovudine, which we would need to check his HB whether he's not anemic, and then also hepatitis B. Remember that first line, the regimen he's taking has tenofovir. So if he's failing and we need to switch him to second line, it means we might need to stop that tenofovir. But you cannot stop tenofovir in patients who have hepatitis B virus infection. So basically for this poll, the best answers are to continue the current regimen, it's a tick, and then enhanced adherence counseling is a tick, and then taking blood tests for HB and hepatitis B is a tick. At this point, we can't switch to second line because we have only one viral load. We can't stop efavirenz and give dolutegravir because we cannot do single drug substitution in patients who have high viral loads, right? So those are the rules regarding treatment. So I'm going to stop and then we need to then continue from here. So viral load monitoring, just remember that the goal of treatment is to suppress the viral load. We want to have all patients who are taking ARVs to have what we call a suppressed viral load, which is a viral load below 50. That's very important. Any viral load that is above 50 should be treated as a medical emergency and it requires action. Please don't discharge or not follow up on viral loads that are high, because when the viral load is more than 50, it means the virus is replicating, it's making babies. And then remember now, it's making babies on a patient who's taking the drugs. So they are likely to develop resistance where the treatment no longer works. So any patient who has a high viral load requires some form of assessment to determine, what the issues are. So that's why when you said enhanced adherence counseling, I said, yes, that's probably the right thing. So a viral load is the recommended, patient monitoring approach in South Africa. Previously, we used to rely on the staging, and then people would become very sick before we diagnose them to be failing. Then we shifted to a CD4 count, and then now a viral load is the recommended method because it is more reliable than a CD4 count to tell us if treatment is working or not. So when we say treatment failure, virological treatment failure, we mean a patient who's got a viral load, a persistent viral load more than 1,000 on 2 consecutive occasions, right? And these viral loads must have been taken 3 months apart with intense adherence support between the 2 tests. So if you look at Josh, we only have 1 test now. And that's why we said, let's do enhanced adherence counseling. For how long? We need to do it for at least 3 months. Then after 3 months, we then repeat the viral load. If the second viral load comes back to be, above 1,000, we can then consider that he has failed treatment and we need to switch him. But for now, he has a high viral load, and then we have not yet confirmed that he's got a virological treatment failure, right? And then also, unless if we know the hepatitis B status of the patient, when we have someone who's got a high viral load, we need to check the hepatitis B status of the patient, because if they do have hepatitis B, tenofovir and the lamivudine should not be stopped, because these 2 drugs, in addition to treating HIV, these 2 drugs also treat hepatitis B. If you stop tenofovir, when you switch to second line in a patient who's got hepatitis B positive, you might cause severe hepatitis or inflammation of the liver, and this is usually not such a good thing to have, right? So how do you interpret viral load results when you do them? So if we did a viral load at the 10-year anniversary and it came back to be suppressed, which is a viral load that is less than 50, we would be very happy and say, wow, Josh, you are doing well, continue taking your treatment and we'll see you again in 12 months time, right? If the viral load was high, but not more than 1,000, let's say a viral load of 600 or 800, we would then do enhanced adherence counseling and then repeat the viral load in 3 months. And based on that viral load, the second viral load, we would then decide, what we need to do. So this is a patient who's got a high viral load, but, it is not high enough for us to be very concerned. If the viral load is more than 1,000, which is our case now, Josh, right? He's got 1 viral load, which is above 1,000. So what do? You do enhanced adherence counseling. You want to repeat the viral load in 3 months' time. So you'll see him every month and make sure that he's got support. You might even bring additional support from home. And then you do blood for hepatitis B and an HB, because you are preparing for, in case the 3 months viral load, when you repeat it, it comes back high. Now you know exactly what regimen would be best for your patient, right? If the first viral load was more than 1,000, and when you repeat it after 3 months, it comes back to less than 1,000, so he's now suppressed. You continue adherence counseling, you don't change any drugs, and then you want to see him after 6 months for a repeat viral load, right? However, if the first viral load is more than 1,000, and then you do adherence counseling for 3 months, and then after 3 months, you repeat the viral load, and it still comes back as more than 1,000. So it means now you have viral load 1 and viral load 2 being high. It means the patient has failed treatment, and then they probably need to be switched to second line. And before you switch, you need to check the results for your hepatitis B and your HB, right? And make sure that between the 2 viral loads, if there's any adherence issues, all those issues are addressed, right? Now, there are patients who might have a high viral load, but they're taking a dolutegravir or a protease inhibitor regimen, right? So the criteria for treatment failure for patients who are taking efavirenz or dolutegravir is not the same, because we know that this drug is a very good drug. Very few patients who have high viral loads are actually failing this drug. The majority are not failing. They might have probably stopped taking the drug, or it might be an issue of drug-drug interactions. So the treatment failure definition for a patient who's taking dolutegravir, we say the patient must have a high viral load more than 1,000 at least 3 times over a course of 2 years. In other words, you cannot say a patient has failed dolutegravir or even lopinavir, ritonavir if they have taken ARVs for less than 2 years, right? So you need at least 3 viral loads above 8,000 over 2 years. Then we start to be very worried. Alternately, if they have not reached 2 years, or they even have 2 viral loads that are high, but now they are deteriorating clinically, that means now they are developing a stage 3, stage 4 condition, or their CD4 count is dropping. Then you can classify them as treatment failure even before 2 years. So just remember, this criteria for 2 viral loads taken 3 months apart, it's a criteria for treatment failure for patients who are taking a regimen, a drug combination that has a efavirenz generally, right? If you're talking about the patient who's taking dolutegravir, you need at least 3 viral loads over 2 years, or a patient who's got a high viral load and clinically they're becoming sick. Then you would classify those patients as failing treatment. So again, remember that when patients are taking ARVs, we must monitor their viral loads. So the first viral load will be when they are 6 months on ARVs. If it is suppressed, we repeat it at 12 months. If it is suppressed, then we do it every year, annually, right? At any given time, if the viral load is less than 50 copies, we are happy. We continue with the regular monitoring. If it is high but less than 1,000, we need to do adherence counseling. If it is more than 1,000, we are very concerned. We will do what we call A, B, C, D, E, where we review adherence problems. We look at if they've got other infections. Are they taking the correct drugs and dosages? Are they taking other drugs that might make ARVs not to work, or maybe they've already failed, treatment? Then whatever you find needs to be addressed over a course of 3 months. After 3 months, you need to repeat the viral load, right, and confirm if you now have treatment failure. So that is very important. So all patients with high viral loads, you must do A, B, C, D, E. Checking side effects, checking if they've got the mental health problems, substance abuse. Maybe they do want to take the drugs, but the social circumstances are a bit problematic. Non-disclosure means the partner does not know that the person is taking ARVs, therefore they are hiding, all these drugs, and so on. Check if they don't have other opportunistic infections like TB and STIs. Are they taking the right dose, especially children? You'll find that the child has grown, but they're still taking doses as if, it's an infant. Are they taking other drugs, and remember, TB drugs, your anti-epileptic drugs can interact with your ARVs, including some of the herbal medicines, right? And then do you think your patient has failed? So you'll assess your patient, and whatever findings you find, you want to address them. You've got 3 months to address them. After 3 months, you take the viral load, and then you decide from there, right? So here's our case study, Josh. Remember, he's taking tenofovir, emtricitabine, and efavirenz for 10 years. And you did the first viral load, which was 9,500. And he tells you that for the past 3 months, since the last viral load, he has been adherent. He has never missed any doses, He's still on the same regimen, no side effects. He's not having any mental health issues, and he's not abusing substances. And now, I don't know why we say hey, but it's fine. So now the repeat viral load is 6,000. So the first viral load was 9,500. Now, after 3 months of interventions, the viral load has sort of dropped a bit. Now it is 6,000, right? So engage with this Josh. So now, what's your plan for Josh now? is in terms of his regimens, are you planning to continue the same regimen, tenofovir, FTC, efavirenz, or you want to switch him to zidovudin, lamivudin, lopinavir, or zidovudin, lamivudin, dolutegravir? Ooh, you know, this language is not English, ne? These drugs. I hope you guys are coping with these drugs. Right? Give it your shot. We have 10 more seconds. Come, guys. Let's all participate. Let's all participate. All right. 5 more seconds. Right. So 5, 4, 3, 2, 1. Okay, I'm gonna stop. Then I'm gonna share the results with you. I'm hoping you can see the results. So a huge proportion are saying, actually, we must continue. And I know why, because I teach a lot. So I know that those who are saying continue is because they saw that, oh, it was 9,000 and then now it's 6,000. Let's continue the same regimen. No. Remember the definition of treatment failure. It says 2 viral loads above 1,000, taken 3 months apart. So the first viral load here, Josh, was 9,500. Is it not above 1,000? It is. Josh, for 3 months, he's been adherent. He has never missed any doses. Again. And then today, his viral load is back. The second one after 3 months is 6,000. Is that viral load above 1,000? Yes. So Josh meets the criteria for virological treatment failure. He's got 2 consecutive viral loads above 1,000, taken 3 months apart with enhanced adherence counseling. So Josh has failed treatment. So don't be confused by the 6,000. Please remember, he has already developed mutations at this point in time. He had enough time to resuppress 3 months. And don't use the logs, because the logs, we use them in pregnancy, because in pregnancy, we don't give patients 3 months to suppress. We give them 1 month to suppress, right? So here, Josh fits that definition very well. He fits the definition of treatment failure very well. Therefore, we cannot continue the current regimen. We need to prepare him for second line ART regimen. And the second line regimens that we need to choose from is the second one and the fourth one. We need to choose the appropriate one: zidovudin, lamivudin, lopinavir, ritonavir, or zidovudin, lamivudin, and dolutegravir. So we need to choose either option 2 or option 4, right? And option 4 being the best regimen for him, because dolutegravir is a very good drug, very few side effects. It's meant to suppress the viral load as quick, as possible. So we really prefer that regimen, right? So let's continue, and then let's see what the theory looks like. So remember, we had a high viral load, then we repeat the viral load after 3 months, and the viral load from Josh came back as more than 1,000, right? Don't say, no, but it went down a bit. No, it's not significant. The virus will play with you. It likes playing games, ne? So if the first viral load was more than 1,000 and the repeat is less than 50, we congratulate him, we are happy. If it went back below 1,000, but it's still high, we can still give him time and continue the same regimen and then give him time. Unfortunately, for Josh, like I said, the first viral load was more than 1,000. We did 3 months of adherence. We repeated the viral load. Now we've got 2 viral loads that are more than 1,000. And he is taking efavirenz as part of his regimen, right? Remember, he's taking efavirenz. Therefore, we need to consider switching him to second line when what has happened? When we have 2 viral loads on 2 occasions and adherence issues are addressed. And that's exactly what we have with Josh. So Josh has failed that treatment. He now needs a new regimen, right? Keep it like that. And remember, I said, if we are talking about your protease inhibitor, or the patient is taking dolutegravir or lopinavir, ritonavir, we need at least 3 viral loads over a course of 2 years. So he's not on DTG. He falls in this criteria. George has failed the treatment, right? I hope you are seeing it. And in terms of switching, remember, some of you said you'll give lopinavir, ritonavir as part of your second line, and some of you said you'll give dolutegravir. The chain of switching is exactly the way this diagram is showing you. If someone is failing treatment and they're taking efavirenz as part of the regimen, when you switch them to second line, you switch them to a dolutegravir-based regimen. You don't go to lopinavir, right? If someone was taking dolutegravir and they're having high viral loads and they are failing treatment, then you can switch them to lopinavir, ritonavir. Right. So if you look at Josh is taking tenofovir, lamivudine, and efavirenz. If he fails treatment, we prefer to give him dolutegravir. If for other reasons, let's say he was a female, he's like 1 week pregnant and he's failing treatment, we want to switch him, we know we can't use dolutegravir in the first trimester. Therefore, we would then just we will switch from efavirenz to lopinavir, ritonavir, because there's contraindications to dolutegravir. But without contraindications to dolutegravir, we move from efavirenz to dolutegravir. Again, in your guidelines, this table is from your guidelines. It is very nice. It tells you that if a patient is taking a regimen, tenofovir, lamivudine, and efavirenz, which is the regimen that Josh is taking, and then they've got the 2 viral loads that are above 1,000, and you have confirmed that this patient is failing treatment, right? And you need to check their hepatitis B status. Remember, we discussed this a bit. I said, don't just switch, because once the hepatitis B is positive, you are not allowed to stop TDF, right? But let's presume Josh has a negative hepatitis B, so we will switch from tenofovir, lamivudine, and efavirenz, and we switch him to zidovudine, lamivudine, and dolutegravir, right? The only time you would give zidovudine, lamivudine, and lopinavir, ritonavir, it's in cases where you are not allowed to use dolutegravir for whatever reason. Usually it will be issues of pregnancy in the first few weeks in the context of our guidelines, right? If hepatitis B is positive, you still give zidovudine, lamivudine, and dolutegravir, right? But the TDF, you must continue it so that we keep the hepatitis B controlled using these 2 drugs. So this is very important, and it gives you, some ideas. Remember what I said, if he was taking tenofovir, lamivudine, and dolutegravir for more than 2 years, and you have like 3 viral loads that are high, you then need to give zidovudine and then lopinavir as part of the regimen. And I'm saying this based on this slide. If someone is taking dolutegravir and they're failing, your third drug would be lopinavir, ritonavir. So this is the rational sequencing of switching to that regimen. So remember, our standard first line regimen in South Africa generally is a combination of, sorry about that, a few seconds. Sorry about that. So just to remind you that our first line ART therapy in South Africa is tenofovir, lamivudine, and a choice of either dolutegravir or efavirenz. If someone is failing tenofovir, lamivudine, and efavirenz, their second line is zidovudine, lamivudine, and dolutegravir, right? If they are failing a regimen that has tenofovir, lamivudine, and dolutegravir, their second line is zidovudine, lamivudine, and then lopinavir, ritonavir. So just remember this choice of drugs, right? And then remember now the doses. So for our second line, remember our patient was taking tenofovir with lamivudine and then with efavirenz, right? Now they have failed treatment. So what is our second line regimen? It's zidovudine, 300 milligrams, 12 hourly per course. And that's why we must check the HB, right? When patients have high viral loads, you must do an HB. If the HB is abnormal, you want to avoid the use of zidovudine. So zidovudine, 300 milligrams, 12 hourly, plus lamivudine, 300 milligrams daily, right? Because the patient was taking efavirenz, then we can give him dolutegravir, 50 milligrams per course daily, right? Where we cannot give dolutegravir, we would then give lopinavir, ritonavir, S2 tablets, 12 hourly, or BD per course, right? So I'm hoping you've taken a picture of this slide, né? Because it's got all the key drugs, their short codes, and then the full names, the doses, how you give the drug, but also some of the things you need to be cautious about with respect to every drug that we need to prescribe, right? And then also, even in second line, you must simplify the regimen for our patient, because yes, if it was first line, we would be giving TLD, one tablet once a day. But remember, we said we're going to give zidovudine plus lamivudine plus dolutegravir. So we do have a combination tablet that has zidovudine and lamivudine. So they will take that tablet BD, right? And then with dolutegravir once per day, whether at night or during the day, it doesn't matter. So we want to minimize side effects and we want to minimize the number of tablets. So that is quite important for us to note. Now, patients who are taking second line, remember, they will be taking zidovudine, most of them. So you want to do your HB before you start zidovudine, and then at 3 months, 6 months, and then every year. Before you switch your patient and stop tenofovir, you need to check their hepatitis B status. If it is negative, your patient will get 3 drugs, zidovudine, lamivudine, and dolutegravir. However, if hepatitis B is positive, we also need to keep TDF in that regimen, tenofovir in that regimen, to control hepatitis B virus. If you have prescribed lopinavir, ritonavir, you would then need to do a fasting cholesterol, right? And if the cholesterol is more than 6, you are not supposed to use lopinavir, ritonavir. You would then prescribe atazanavir. So those are the rules, and they're in your guidelines. So just to talk about the issue of HIV and hepatitis B co-infection, just remember that in terms of our first line regimen, generally most patients are on tenofovir, lamivudine, and let's say efavirenz in this instance in terms of our case, but it can either be DTG or efavirenz. It's a choice between the two. Note that these 3 drugs do manage HIV effectively. However, tenofovir and lamivudine also treat hepatitis B. So patients who have hepatitis B and are taking our first line regimen, we should avoid interrupting tenofovir and lamivudine or FTC in those patients. Therefore, and you should note that if a patient was taking first line and they have a high viral load times 2, taken 3 months apart, when we switch them to second line, their second line would be zidovudine, lamivudine, and dolutegravir. In this instance, you would see that tenofovir has been stopped, right? However, as you switch patients from first line to second line, you need to check their hepatitis B status. If the patient has both HIV and hepatitis B, you would give your second line regimen, which is zidovudine, lamivudine, and dolutegravir, right? But because they also have hepatitis B, you must keep TDF in that regimen. So TDF and lamivudine would manage hepatitis B nicely, and then zidovudine, lamivudine, and dolutegravir would then treat HIV. So both conditions need to be treated. So the rule is never interrupt tenofovir and lamivudine in patients who have HIV and hepatitis B. When changing regimens from first line to second line ART, always verify and check the patient's hepatitis B status. If the hepatitis B status is negative, this would be their second line regimen with just 3 drugs, zidovudine, lamivudine, and dolutegravir. If the hepatitis B is positive, then the patient needs 4 drugs, TDF and lamivudine for hepatitis B, zidovudine, lamivudine, and dolutegravir to manage the HIV infection. So please don't forget, it's a very critical clinical governance issue. Right. So in summary, dolutegravir is a significant game changer in the antiretroviral treatment in South Africa. It has a high genetic barrier. That means most patients would never get to fail treatment in their lifetime. As it stands, it is well tolerated. That means it got very less side effects. However, there are drug-drug interactions with TB drugs and other drugs, including metformin. So you need to always check, the drugs that you are prescribing with dolutegravir. There's also a possible risk of neural tube defects, so there's implications for women with childbearing potential. So we prefer that they must be on reliable family planning options. And then we need to integrate HIV services with family planning and maybe avoid it in the first few weeks of pregnancy. Remember, viral load suppression is defined as a viral load less than 50. And then any viral load above 50, remember, it means the viral load, the virus is now replicating, the patient is likely to fail treatment. Those patients, they need to be assessed using ABCD, adherence, checking infections, the doses, drug-drug interactions, and then intervene, repeat the viral load. Never switch only one drug in a failing regimen. Like in our case, when the viral load was 9.5, some opted to say, no, we'll just change efavirenz to DTG. No, that's not appropriate. You need to be patient, do your adherence, repeat the viral load in 3 months. If you have 2 viral loads, more than 1,000, your patient has failed. And if someone has a high viral load, they probably need a new regimen, not just one drug being switched. So that is quite important. And then virological failure requires a complete new regimen, right? Which is very important, not just one drug. And then resistance testing is indicated for patients who are failing other drugs like yolopinavir, ritonavir, and dolutegravir, but not for failing efavirenz-based regimens. Right. Yeah, so just to say, remember, study with your friends and enjoy. Right, so I really hope for today's session, you have managed to grasp, something positive. Yeah, and that was the lesson for today. I hope it was worth your time and effort. Yeah, I'm gonna stop the recording.